So I'm going to start with a case just to kind of set the tone for everyone to make sure that they can have a picture of here of the kind of patient that we would consider treating for with opioid agonist therapy. So I'm going to talk about Eddie. He's 35, and he shows up in the emergency room, and he's got a left arm cellulitis with some obvious track marks from intravenous drug use. And he tells you that the last time he had a hit of 2 daily 8s was 2 days ago. I think it's important to understand that there is a language in addiction as well, and there's lots of words that you shouldn't try to use yourself or try to sound cool by using, but certainly if people use words that you don't know, there's nothing wrong with asking them and acknowledging that that's not your language, and potentially that can help you to get a good idea of some of the street names of some of the drugs on the street. So Dilly 8 in this case would be Dilaudid 8 milligram tablets. Okay, so he was admitted to the hospital 4 times in the last 2 years for addiction-related complications like endocarditis. He had a lumbar spine discitis, and then he had a paraspinal abscess, and he had 2 other admissions for cellulitis. And every time he comes to the hospital, we treat his infections, his acute problem, we manage his pain with IV, and then we step down to oral opioids. And last time he was in the hospital, we didn't do a very smart thing. We sent him home with a 1-month supply of long-acting opioids to manage his pain and told him to follow up with his family doctor. So we kind of threw the frisbee and we're hoping somebody else would catch it and do something better than us. Every time he's in the hospital, we offer him an addiction referral, but he never takes us up on it, and he just keeps returning over and over again with problems or complications associated with his addictions. The only other thing to note is he has a past history of Hep C and depression, and he's asking you right now, he's looking pretty sweaty and edgy, and he's moving around in his room, doesn't look too hot, and he's asking for some IV dillies to take the edge off. So what is this guy's real medical issue? What's his real medical problem, and how can we help him is what we're going to focus on today. So we're going to see if we can diagnose an opioid use disorder and recognize withdrawal in a patient, and if we can initiate Suboxone for opioid agonist therapy specifically. So I will talk a little bit about methadone, but I'll mostly talk about it to tell you why I love Suboxone so much more. And then we'll talk about how you would transition this patient into the community, because I think one of the big problems often happens is we'll do some management, either good or bad, in the hospital, and then when they get back out in the community, things can fall down. So you really do need to have a really solid discharge plan for patients with addictions, because you know, it's easy to fall back down when you don't have supports set up around you. So why do we care about this topic? Why have I been asked to speak today? So in North America, drug overdoses are soaring. It's a deadly phenomenon largely driven by our own opioid prescribing practices. During COVID specifically, the ability to access healthcare has been restricted, and patients' mental health has been badly affected, and that's going to make the situation worse for people struggling with addiction. As of May 4th, there had already been 233 overdoses reported to Regina Police, and that was over a 4-month period. That's 3 times the number of all the overdoses all of last year. So we know that this opioid and crystal meth problem is skyrocketing, and we know that COVID is further exacerbating it because people don't have access to drugs. Nationwide, 47,000 deaths are linked to substance abuse, and it's cost our healthcare system more than $8 billion. Unfortunately, Saskatchewan's one of the highest rates of hospitalizations for opioid poisoning, and our opioid use disorder-related visits has doubled in the last decade. We have an opportunity when people show up at the hospital to manage their addictions, but we often only look at their acute medical issues, and then we see them again and again, and that we don't treat the underlying medical issue, which is addiction, and so we end up dealing with expensive, prolonged, and providing not the best medical care for patients. Unfortunately, the Indigenous peoples in Saskatchewan are disproportionately impacted. This is due to lower average socioeconomic status, poor living conditions, trauma, violence, and the legacy of colonization. And opioid-addicted patients are diagnosed with Hep C and HIV at the same rates as some places in Africa. So this crisis in Saskatchewan demands that we engage both in the hospital and out in the community to manage addictions. So why do we care about addictions in the hospital setting? Why does it matter? Why don't we just treat their acute problem? Well, we know that addictions overlap with many common medical problems that are treated in the hospital, like cellulitis, septic arthritis, endocarditis. We know that addictions result in against medical advice, leaving, readmissions to the hospital, prolonged hospitalizations, and that leads to bad outcomes. It's expensive, it's not good for the patient, and it's frustrating for the caregivers as well. We know that many of the conditions that you can get from addictions end up bringing people to the hospital, such as cellulitis, Hep C, HIV, and at the point where you're newly diagnosed with one of these problems, that's an opportunity or time where we can sometimes say, now's the time to make a change. This is really poorly affecting your health. Now is when you might be motivated to do something. So if not now, when? What medical problem or what bad outcome is going to make you change, if not having, for example, a new diagnosis of HIV or an endocarditis that's causing heart damage? So what should we do as a hospital provider? We need to treat not just the acute medical condition, but the withdrawal the patients are experiencing and their opioid use disorder, so that they don't need to come back to the hospital again and again with complications. And then we need to make sure we're linking them in the community as well. So we need to think of addiction as a chronic illness. There's a lot of misunderstanding and judgment around addictions. So I like to liken it to diabetes. When a patient's diagnosed with diabetes, even if partly it's because they're overweight and they make poor food choices, nobody makes judgment on them that they might need to take insulin for the rest of their life to manage their diabetes. But when someone is diagnosed with addiction, the fact that they need to take a drug to help manage their addiction often comes with judgment. This is a biological disease. It does make changes in your brain chemistry. There are lifestyle things that you can do, counseling, engaging in good sleep hygiene, good health practices, but often we need medications, and this is something that we can't get frustrated on. It does have a relapsing and remitting course. When your diabetic comes in and their hemoglobin A1C has made a big jump, you know, we don't say, well, I give up on you then, you're not trying yourself. So we need to feel the same way about patients living with addiction. So why would we use opioid agonist therapy? Why don't we just tell patients to tough it out? So we know that detox alone doesn't last. So whether patients go into a detox facility or they do a day program or they just quit on their own, we know that less than 20% of patients last more than 30 days after a detox attempt if you don't start some sort of opioid agonist therapy. We also know that opioid use disorder medications promote recovery by reducing the use of injection drugs, reducing infections, reducing criminal behavior, and promoting return to work and family obligations. So opioid agonist therapy works. It sometimes is only for a shorter period of time, months to a couple of years, and sometimes people need it for life. A lot of prescribers feel that they feel uncomfortable with prescribing opioid agonist therapy, and they don't want to fill a prescription. If you have a patient admitted to the hospital or you're seeing them in the emergency room and you are you don't have any special training, you can continue their prescription at the same dose that it's at to prevent the complications related to abruptly stopping their prescription. So I just wanted to reinforce that even if you're not super comfortable yourself and you're waiting for a consultant to come and manage their addictions, you can continue to prescribe the same dose of the opioid agonist therapy that patients are already on. So why do I like Suboxone so much better than methadone? So I consider methadone to be the warfarin of opioid agonist therapy. It has lots of drug interactions. We need to be mindful all the time whenever we start an antibiotic or lots of medications that patients often need that we're going to have a side effect that interacts with methadone. The most scariest thing about methadone is that it can cause QTC prolongation, which is a funny heart rhythm that can become fatal if it turns into torsade de pointe. So it is a drug that has really serious side effects and shouldn't be taken lightly. And when we have another drug out there that is just as effective, why wouldn't we choose it? The other thing about methadone is it's a full opioid agonist, and unfortunately in Saskatchewan, methadone itself is a drug that's being widely abused. So in the top right corner of the slide you're looking at there, it's actually the coroner's report, and you can see that people have died of a methadone overdose as frequently as they've died of hydromorphone and morphine. So that's a scary prospect that actually the medication that we're using to help manage addictions is also causing accidental overdoses. So I think it's really important that you use tools and motivational interviewing with patients to really sell the benefits and features of Suboxone. So one of the talking points that I like to use with patients is at the right dose, Suboxone controls withdrawal for 24 hours, so you can feel normal and not sick or high. Although some people think that it's just replacing one opioid with another, you can take this medication, get rid of your cravings, break your patterns associated with misusing drugs, and focus on getting healthy. So I have attached, I'm not sure, I hope that Jason also attached it, but I will make sure that it's sent out or connected with this presentation, a really nice opioid use disorder tool from Center for Excellence in Practice. It has lots of these great talking points that you can use when you're talking to patients about the benefits of treating their opioid use disorder with opioid agonist therapy, and specifically what we like about Suboxone. So I think it's worth reading through just to have those words that you're trying to, when you're talking to a patient and you really want to have the best shot of them saying yes, because sometimes you have to talk to patients over and over before they say yes. You want to have those words that really like hit home for patients. So I'll make sure that that's also connected. It's a great resource. All right, so you've decided you want to do Suboxone. You've decided, you know what, I like it better than methadone. I know it's a safer drug. I know I don't have to worry as much about interactions. I know it's not as likely to cause an overdose. So I'd really like to talk a patient into starting them on Suboxone for their harm reduction or their opioid agonist therapy. So there's actually a couple ways to start Suboxone, and I think it's really important when you're talking to a patient about starting Suboxone that although you're taking away the choices of medications to start, you could at least give them choices around how you're going to start it. So I like to present patients with a menu of options so they feel that they have some choices, but obviously I want them to be safe choices and choices that I think that are going to be successful for the patient. So there's two main methods that we're going to talk about today in terms of starting Suboxone. The classic method, which probably if you know anything about Suboxone is the one you're most familiar with, and then a method called the microdosing method. So either method can be used, and in certain situations, one can be better than the other, but I think it's really important to present both choices to a patient so at least they feel they have some choice in the matter. So in terms of the classic method, we like that method when a patient's already presenting to you that in withdrawal, and the nice thing about it is they can quickly be stabilized on this medication over a couple days, and it's also the best known method. So another attached document, and in the references you'll find from the BMJ, is a nice, easy two-page reference that explains how to start Suboxone with with the classic method, and I will go through it a little bit, but just so you know that there's a nice two-pager that can go through all the main points around starting classically. The other method is called the microdosing method. Now this method is a better choice to use in patients who are very fearful of going into withdrawal, and they are using really just to avoid getting into withdrawal symptoms. So some patients will do a lot of crazy things to not have to feel withdrawal. So this method allows you to slowly introduce Suboxone while they're on their drug of choice, their full agonists, like, for example, Dilaudid or morphine, and you maintain a dose of that while you slowly introduce the Suboxone. And over the period of a week to a month, depending on how slowly you do this, you actually fill up the receptor slowly, and you don't send them into the precipitated withdrawal that you would if they tried the classic method. And we're going to go through both examples coming up here. So let's start with the classic method. So again, the BMJ two-pager will be linked to this presentation and can be found in the references. But the key is you need to make sure that this patient is in withdrawal before they start the medication. So on the right-hand side of the slide here, you can see something called a COWS. It's a clinical opioid withdrawal scale, and it helps us to determine how much withdrawal the patient is in. And you want them to be at least a score of 12, which you'll see if you look at these numbers isn't very hard. So if someone is in your office and they look uncomfortable, they're likely a high enough score to start Suboxone. But you can see it's based on things like their pulse and whether they're sweating and all the things that happen when a patient goes into withdrawal, like yawning, tremors, goose flesh, anxiety, irritability. So you want to score them and ensure that they're at least a 12. And the reason you do that is because if they aren't in enough withdrawal, when you give them the Suboxone, because it latches on to the receptors better than full agonists, it will push the full agonists off and they'll get a precipitated withdrawal. And nobody wants to start this again or try this again if they get a precipitated withdrawal. So a kind of good rule of thumb is if someone was using short-acting agonists, you need to wait about 12 hours, long-acting about 24 to 48 hours, and methadone, usually we want to wait at least 5 days, and usually a specialist would be involved if you were going to have methadone as the starting point. So if they do take their first dose and they go into withdrawal, they need to stop and wait 24 hours and try again, and you need to explain to them what happened. So it is really important that they do get into withdrawal before they start this medicine. So you can see on the top left there, you just start Suboxone at a dose of 4 milligrams. It's taken sublingually, which means you let it dissolve in your mouth. And their withdrawal symptoms should get better when they take their first dose of this. And after 2 hours, if their withdrawal symptoms have come back or they're not completely gone, you can give them another dose. So by the end of the first day on this classic initiation, you've got them at a dose of 8 milligrams of Suboxone. And then on day 2, you can continue on. If they're still in withdrawal the next morning, you can give them the 8 milligrams plus another 4, and then 2 hours later another 4 to get to a total of 16 by the end of day 2. And you can keep titrating up by 2 to 4 milligrams a day to a max dose of 32, although there isn't a lot of evidence for harm reduction or for opioid agonist therapy of effectiveness beyond 24 milligrams. So if 24 milligrams isn't working for their withdrawal, then 32 probably isn't going to, and they need to be considered for an alternate treatment plan. There is a quick rapid start. So on the bottom right-hand corner of this slide, you can see there is a rapid start option for patients who you know are going to need a much bigger dose than 8 milligrams by the end of the first day, and you want to get them quickly to that dose so that they don't bail on you and go AMA from the hospital because they're in withdrawal looking for drugs elsewhere. And so you can actually start some patients right at 8 milligrams, an hour later give them an extra 8 milligrams and get them to 16 by the end of the first day and up to 32 by the end of the second day. But again, usually if you're needing to kind of go off the regular prescribing, you would ask an expert to help you out with that. And again, they do need to be in withdrawal to do this method. So here's an example PPO. So all over the world, North America particularly, we have been trying very hard to come up with plans and ways to make Suboxone the drug to choose for opioid agonist therapy and make it simple to start it and get people educated about how to start it and get comfortable with it. So we know that pre-printed orders in hospital result in guideline-based care, and you can see using a pre-printed order like this gives everybody confidence that they know that we are doing something safe, and also gives all of the other withdrawal medications like Tylenol or ibuprofen, ondansetron, or clonidine for withdrawal symptoms while patients are getting titrated up onto a good dose of Suboxone. Okay, let's talk about the other method, because some patients, you know, that idea of going into withdrawal is just, it's the devil to them, and they're going to avoid it at all costs. But some of those patients really need a way to get onto Suboxone and get out of this cycle of IV drug use, withdrawal, and repeating over and over again. And so there's another method called the Bernese microdosing method, and there's several different recipes for this. I don't have one pre-printed order that I can give you. There is an attached article about some of the different ways to start this. But the theory behind this is you're going to start with a tiny dose of Suboxone while the patient is still on a full agonist. So for example, if your patient comes in and says, I use 8 milligrams of hydromorph Contin 3 times a day IV. We know that IV is twice as strong as oral. We know that hydromorphone is 5 times as strong as morphine. We work out a morphine equivalent for that medication. So I said 8 times 3, which is 24 times 2, because I use IV, that's 48, and then I times that by 5. And then we, to be safe, would drop back about half the dose of what they're reporting, because patients often will over-report what they're using. And we would use that as a medication dose to start them on while we start their Suboxone. And you can see on the right-hand side of the slide there that we slowly, over time, introduce Suboxone over the period of 7 days. And on the 7th day, when we've got them at a good dose of Suboxone, and we know that getting to at least 12 milligrams of Suboxone does increase your chances that patients will stay in the program, you would slowly bring them up to that dose. Then you can stop their full-acting agonist, and that slow introduction has allowed the Suboxone to slowly push all of the full agonists off the receptors, and they shouldn't experience the withdrawal like they would if they did a quick start. I'm not saying there will be zero withdrawal, but it will be much minimized by this slow dosing. And you can see initially you're doing twice a day, so you're slowly hitting that receptor twice a day. And then on the last day, when you get to the good dose of Suboxone, it's a once daily formulation. In the notes section of this slide presentation, which will be available, I've given you 4 or 5 other protocols. This is just one example that I've done here for a week. Dr. Wilna Wildenbauer is our opioid agonist therapy expert at 1048 Albert Street, our harm reduction clinic. And she has a nice 1-month one for patients who really are nervous about switching from methadone to Suboxone, and she can slowly get patients up over a month, and she's had great success with that. The next thing to consider is you've done all this great work to get a patient on a medication like Suboxone. You've got them managed, they're ready to go home, and now they're going to walk out into from the hospital into real life, where they're going to have all their previous temptations, all their previous social groups, all of those things. So I think it's really important too to remember that we can't just expect the addiction issue to stop when they exit the hospital simply because we put them on a good dose of a medication. So we know that addiction requires not just medication, but also a good support system, counseling, and so we need to make sure that those are set up. So you need to find out before the patient leaves the hospital if their primary care provider can prescribe their medication, whether they need to go to the harm reduction clinic. Most people in Regina that are on Suboxone are going to an opioid agonist therapy clinic until at least they've been stabilized for a period of time. You need to be flexible. If it's the long weekend and their Shoppers Drug Mart isn't open on the Monday and the only way for them to get their Suboxone dose is to come back to the emergency room, then you need to be able to make that happen. We want to make this as easy as possible for them to stay on this medication until they get into the community and linked to care. You don't want to say to the patient on discharge, hey, you better phone over and make an appointment at the harm reduction clinic by 5 days from now, because that's all the medication I'm willing to give you. You need to actually phone the clinic, get an appointment for them, give them exactly the amount of medication they're going to need until then, explain whether or not it's witnessed, and all those steps. You could do all of that, and sometimes they still don't show up, but certainly if you just leave it in a patient's hands after you've done all this work, it's not that they're bad people or they make bad decisions, but we need to acknowledge that people need to feel supported, and they need to feel a really like a team approach when they're getting back into the community. You want to make sure that if they have been found to have HIV or Hep C, that you've linked them for treatment with that. You want to review safe injection practices in case they do relapse. You want to make sure they know about where the needle exchange programs are. You want them to know that you're not going to give up on them, you've got a clear plan for them, and you want them to be received by a team in the community that's going to help to keep their success going forward. So back to the case with Eddie. So, you know, Eddie, depending on what Eddie wants, we could use any of the methods that I discussed today to get Eddie on Suboxone. So I think it's very important, first of all, that we get Eddie to acknowledge that you know, what he's doing up to this point has not been working for him, that we do want to manage his pain, and we also want to manage his addictions, and that we're willing to work with Eddie, but we really want to stop this cycle of him returning to the hospital with complications from his addictions. Now, Eddie's already in withdrawal, so if he's game, you could start him on Suboxone using the classic method, or the rapid method, which means getting him quickly up to a bigger dose. If we know Eddie uses a high dose of opioids like fentanyl or heroin in the community, he's going to need a quicker start. Or we could say to Eddie, hey, Eddie, you're coming to the hospital anyway to treat your cellulitis. Why don't we manage your pain and slowly start you on Suboxone and get you to a comfortable dose? And then once we've got your pain under control and you had a good Suboxone dose, we'll discontinue that Dilaudid or whatever the drug is that you're going to use to manage his pain, and your pain and your addictions will be managed. And then Eddie has some choices, and Eddie gets to decide and take some control in his decision around how he's going to manage his addictions. But one of his choices shouldn't be, I don't want to do anything about this, right? This is a chance, this is an opportunity to have what I like to call a come to Jesus moment, an opportunity to really get Eddie to see that this pattern needs to change for him to have a life. At this point, his life is about addictions, and it's not a very good life. Another thing I just wanted to touch on before I end today is talking about using Suboxone for pain. So a lot of the new literature coming out now is actually suggesting Suboxone can be helpful as well in managing pain. We know that we've been using high doses of full agonist opioids, and we know that there's not good evidence to manage pain with full opioids, especially chronic pain, in doses greater than 90 milligrams a day. So Suboxone can also be used for pain, and people who are already on Suboxone can also have their pain managed by splitting their Suboxone dose. So Suboxone is used for the opioid agonist therapy on a once daily treatment plan, but if you're using it for pain, you actually have to break the doses up to 3 or 4 times a day. So for example, if someone is on Suboxone 16 milligrams and they come into the hospital and they're having pain, don't stop their Suboxone. That's not going to help you in the long run. You're going to have to stop it and then restart it, and that's very challenging. But you can manage their pain by, first of all, breaking their dose up into 3 to 4 times a day. And you can actually use Suboxone as well as a PRN painkiller, up to a dose of 32 milligrams a day for pain management. Don't forget about the other things we do to manage pain. And I think a lot of times people forget when a patient comes in with addictions and they're opioid tolerant, and their patient is asking for, escalating doses of opioids, about the other things you can do to manage pain, like heat therapy and cold therapy and compression and wound dressings if someone has an open wound. Young patients often could tolerate an anti-inflammatory, so that's another, to take down swelling. So don't forget about those things. And then we do have some specialists in the hospital that you can sometimes access for regional nerve blocks. And we have some specialists that are coming as well into our health region, which are going to, I think, give us some more options in terms of managing pain with not opioids. If someone has, chronic back pain, there's evidence for the TENS machine. So there are some things we can do that are not opioids, as well as we can leave them on their Suboxone and use it as an acute pain medication as well. And often with good success. Now, there are some situations where you're going to need to take someone off of Suboxone. For example, if they need a spinal surgery, you would have to stop their Suboxone, use a full agonist to manage their pain, and then restart it. But if you want to try, at least in most cases, to leave people on their Suboxone and use it to manage their pain. And then finally, in terms of giving you just some basic tips about how to dose opioids. So a lot of times when people come into the hospital and they decide, okay, I'm willing to start Suboxone, but I only want to do it if I don't have to be in withdrawal. So you decide you're going to do the microdosing method. We don't know what if they aren't on a prescribed medication, we're sometimes not sure what the right dose of the full agonist we're going to use until we get them to the dose. So if someone is using prescription opioids and they can tell you their dose of how much they're using and what route they're using it, you want to start that medication at about 50% of whatever they report as their medication of choice to cover them while you start the Suboxone. If they're using a street drug and they're talking about points of fentanyl or heroin, we don't know what the dose equivalent is of that. So we often will just say, as a rule of thumb, start them for pain management on 10 to 20 milligrams every 3 hours for pain and withdrawal, and dose it to effect. And once you figure out what that is, then you can start to titrate up their Suboxone. Whenever you write a prescription for opioids, particularly some of these patients are going to need quite high doses of opioids, you want to write a naloxone prescription as well. So withdrawal is uncomfortable, but overdose is fatal. Don't forget that. Always have naloxone on hand. Make sure your patients know, if they're at home, know how to use naloxone or a family member. In the hospital, you should use liquid formulations of painkillers, and you should use them for everybody, so there's not a stigma associated with either having to crush tablets in applesauce or someone just using liquid formulations with certain populations. Hydromorph is the preferred opioid to use if someone's renally impaired, but also keep in mind that Hydromorph or Dilaudid is the drug of choice of Saskatchewan IV drug users. And so you will often have patients who will specifically want to be on hydromorphone because of this. And you do need to be mindful of them cheeking their medications and or diverting them. Questions? So I can't see the typed area here to know if people had questions.
Yeah, thanks, Sarah. No one has put anything in yet there. I'll just make a note too that I did put links to those resources that you sent to me in there. It looks like we do have our first question here. So from Leah Grace, if Suboxone is not working, what would be the alternate treatment plan? Methadone? Question mark?
So for opioid agonist therapy, yeah, your second choice would be methadone. Historically, and in other parts of Canada, there have been other medications used, like Cadian, which is a 24-hour acting morphine, but our preference in Saskatchewan is Suboxone first, and then methadone if Suboxone is not working. But again, ideally, we much prefer Suboxone, and we much prefer to problem solve, trying some different things with withdrawal medications to see if we can get them stabilized on Suboxone. But there are situations where methadone, and then over time bringing their methadone down, titrating down to a dose of 80 milligrams or less of methadone, and then trialing them onto Suboxone has to be undertaken.
This will work better, I think. If anyone has any questions, feel free to unmute yourself or go ahead and type into that chat box there, and we'll just give people a handful of seconds here to go ahead and do that.
And then the very last slide on the presentation has all the links I discussed, and as Jason said, it'll also go out attached with the presentation.
You have a question from Leah Grace.
We already had that one.
Yeah, okay. We just did that one. Yeah, so there's links in the chat box there.
I answered all the questions. I'm so good.
It's stunned silence out there. Have you had any experience with Sublocade from Jen?
So yes, we've recently got that covered through the Drug Advisory Committee, and I've taken, so it's quite easy to take the training on that. It's really a few questions if you've already got your Suboxone license. You take a 1 hour little webinar on it. So we are working towards, over the next few months here, transitioning as many of our patients who are stable on their Suboxone orally onto Sublocade, just to simplify things for them, particularly during COVID, to minimize visits. So Sublocade is, for anybody who's wondering what Sublocade is the injectable version of Suboxone, and it's once every 4 weeks, which is a nice, easy thing as opposed to going to the pharmacy once a week or 2 weeks or daily, at least initially. So all you need to get onto Sublocade is to be stabilized on your Suboxone for a week. So that's it's going to be a great thing to be able to get a lot of people more freed up, and their lives more freed up by getting them on Sublocade.
Sarah, I found a lot of, like, your presentation was really good, very informative. You really expressed the importance of the connection between acute care and community. And that's one thing, I guess, to perhaps some of the audience members might be asking, like, this is great advice, great. I still kind of feel like I'm on an island by myself. I can access these resources, but how do I make that connection from the community into the acute care system, or how do I make that connection from acute care out into community? Like, is it as simple as calling the harm reduction number or the chronic pain number? And again, full disclosure with regards to the chronic pain clinic on Albert Street, we're in the process of building this clinic. It was something that was a day and a half a week, and we're moving to a 5-day a week. We've increased our prescribers, our clinicians that are here and can take on some of those more complex cases. But like, what are sort of backdoor ways that as clinicians you can connect, or what kind of things are going on in the acute care system right now where you guys are trying to connect? Is there anything specific going on in comparison to, I guess, what I'm trying to do in community and get that connection point?
So yeah, we are trying to establish a pre-printed order to use for Suboxone starts in the hospital. So I think that's one thing that from a hospital setting we're trying to do. Certainly, you know, as I discussed earlier, I call when I have my patient leaving the hospital and I make an appointment at harm reduction. I think it's really important to have a harm reduction expert in your back pocket. So make friends with somebody in your community that specializes in this, so that you can, I often get calls, texts, and Dr. Wilsenbauer, I'm sure, would say the same thing, of people who know me and are just asking for some advice around managing a patient who they have in their practice that has addictions. I think it is, you know, a very worthwhile activity as well to go and see your local harm reduction clinic and see what's involved in it, and chronic pain clinic, see what sort of services are available to your patient, because you do really want to make sure that you have a menu of options. I can certainly pass the brochure that's used for accessing the harm reduction clinic, as well as there is something called a Regina Street Guide that has a lot of the harm reduction resources on 2 pages that the University of Regina has provided that can be useful to share with your patients. But I think that, you know, the key is actually making sure that you are making a link with a care provider once they leave your hands, and acknowledging that it's not just the doctor care provider that you need to link with, but you know, addiction requires a whole interdisciplinary team. So it might be the addictions counselor that is like your main go-to person, but making sure that you have someone that person can make a personal connection with, because you know, they do need that cognitive behavioral therapy, that motivational interviewing, ongoing supporting them as well. We are working as a hospitalist program as well with the chronic pain clinic towards establishing some transition clinics and making sure some of our highest risk patients are being followed in the community shortly after discharge, just to improve them being compliant with care and their addiction cycle being broken as well.
That's great, and I guess that really fits again with kind of what I'm trying to do as the manager for the chronic pain clinic, as well as stewardship and clinical appropriateness for the opioid stewardship program, is trying to develop, and I guess it's my hope that as we move through and sort of the restrictions with COVID start to lighten, that the intent is that come September, that kind of thing, I'm going to be working with our research team and then some of the physicians on both sides of addictions, and to kind of do like a project connection point starting in September, where and we'll be sending out, I'd like to send out a preamble with the slides to what that exactly does that mean, and how are we trying to make those connections within the Regina area to support patients that are transitioning in and out or back and forth from, you know, and looking for other people that are looking for some of those answers.
And I think a lot of people feel that, you know, this comorbidity of having pain and addiction is uncommon, but it's very common. And sometimes the pain condition comes from addiction, and for example, they got osteomyelitis and an abscess, and now they have chronic pain from that. And sometimes the pain condition was the first problem, and they got their first opioid prescription from their doctor. But regardless of the way that it happened, I think we do really need to get comfortable working together between addictions and chronic pain, because this is a very common patient that has a comorbidity of both addictions and pain, and often many mental health issues as well, just to further make it complicated and need a big team.
Yeah, it's kind of that egg and chicken thing, right? Which came first. So great, thanks very much. I've kind of now
thanks very much for presenting for us today, and thank you everyone for joining us. I think we'll stop there. If you have any further questions, you can certainly email them our way, and we'll connect you with Sarah. And as she mentioned, we will send around the slides and the resources for you all to check out. So thanks again, everyone, and we will hopefully see you again next month.